Hello Dental XP members. Thank you for Dental XP to invite me again to talk about positive and negative factors. I'm Joseph Choukroun from Nice, France, and I'm happy to come back again for a new paradigm. In implantology, we put implants and sometimes we lose bone. We do some graft and sometimes we lose the bone. Implants, sometimes they lose the bone around. And then we can ask a question: how to maintain the bone, grafted or around the implant? Biologically, we can answer. A tissue that wants to live long has two obligations. First of all, must have a full blood supply at the beginning, but this blood supply must maintain throughout its life. This is an example of a full blood supply. The tissue is alive, and this is an example of a failed blood supply. The tissue cannot survive without blood supply. And if I want to give you a nice definition of bone, I will say bone is like a very beautiful lady. When we meet her and we fall in love, then we want to spend a lot of money to seduce her. This is what we do when we want to make bone. And after a while, we achieve the seduction. But if we do not maintain the expense, and you know the behavior of the ladies, they will move away. This is exactly the same for the bone. If we can maintain blood supply, we will meet resorption. All the failures that we meet in oral surgery, we can say this is only a failure in the blood supply, in the installation or in the maintenance. Then we have two objectives. First is how to obtain this blood supply, but the second sentence is obligatory: how to maintain it. Let's go to talk about angiogenesis. Angiogenesis, the installation has to be very quick, and for that we can use growth factors, any kind of growth factors. But it's not enough today, because we have more information, more scientific evidence about the regeneration which need angiogenesis and growth factors, inflammatory cells and stem cells. The question is, can we improve? Can we increase the cytokines release? Can we increase the leukocytes? And can we use mesenchymal stem cells? The objective is to produce a smart blood concentrate. Do we have to increase the white cells? Of course, because they produce large quantities of pro-angiogenic factors, including VEGF. Osteoblasts, they need inflammatory cells to enhance the in vivo vascularization. And the inflammatory cells are the niche for the mesenchymal stem cells. That is what we know from the science. But if we increase the inflammatory cells, do we increase the inflammation? Definitely no, because we have to understand what is inflammation. We have two kinds of inflammation. Physiologic, coming from inflammatory cells. This is a classic behavior when we want to heal. We need inflammation. And we have the pathologic inflammation coming from giant cells. They're cells that induce foreign body reaction. And this is why we do not worry about physiologic inflammation. But we have to answer also about the question, who induces inflammation? Of course, the surgery, your hand, your bisturi. And if you want to block the inflammation, if you want to reduce, the only one solution is to use corticoid, because they reduce the inflammation by inhibition of pro-inflammatory protein and inhibition of expression of interleukin and TNF-alpha. I suggest to you to give just one dose pre-op of dexamethasone or prednisolone. Dexamethasone is 0.20 milligram per kilo and prednisolone is 1 milligram per kilo. It's enough to reduce dramatically the inflammation and the pain. Then, can we increase the cells in the blood concentrate? If we take 2 tubes and we apply 2 different G-force, we can understand that with high G-force we push the majority of the cells into the bottom. And if we reduce the G-force, we can keep more cells at the top of the tube. This is the concept of the low-speed centrifugation concept, the LSCC. We just published this month the paper who is creating this concept, the LSCC. And this is how I designed the new protocol. Advanced PRF, which is just a PRF enriched in white cells, and the iPRF, who is a liquid enriched in white cells. This is the low speed concept. When we decrease the G-force, we increase the white cells, simply. When we decrease the G-force, we increase the cytokine release. And when we decrease the G-force, we can get mesenchymal stem cells from the blood. The low-speed centrifugation concept, we have more cytokines. But does this concept affect the release? Yes. When we see the APRF plus comparing to APRF to LPRF, we see that we can release much more cytokines. What is APRF plus? It's the achievement of the full low-speed centrifugation concept, reducing the RPM and reducing the time. Actually, we spend only 8 minutes. And as we save more cells, and especially more inflammatory cells, we see that we can get more cytokines, and of course, we will get more vascularization. This is a study we submitted recently, and we show that the angiogenesis is much higher when we decrease the RPM and the time. In the clinic, when we want just to improve the soft tissue, we just need to improve the vascularization, and then it's easy to see how we can get a very nice keratinized tissue with a very simple procedure without any bone graft or any connective tissue graft. Do we need BMP? I don't believe, because PRF combined with osteoblastic stem cells induce bone formation in ectopic site. Means PRF can do the job of BMP, but not with the same cost. This is the concept of iPRF. No additive, no anticoagulant, no gel. But the objective was to get especially the stem cells, because we spin the tube at 700 RPM and 3 minutes, because the low speed concept is not only the RPM, it's also the time of the speed. And obviously we need to use them both. And this is how, when we mix APRF and iPRF in the treatment of recession, of full arch recession, we can expect a very nice healing and very nice coverage when we add on the fibrin bed the mesenchymal stem cells. Can we improve the papilla? Yes, by the injection of stem cells, not into the papilla, but behind the papilla, because we cannot inject into the papilla, but injecting behind in the contact of the periosteum, then we can improve the papilla and we can close the black holes. We have today several indications for iPRF: injection in the knee, injection in the TMJ, and we see that we can expect a cartilage regeneration with the stem cells. Today we use also IPRF for skin regeneration and wrinkles. This is a treatment who can be done by the dentist because it's the dental area. We can improve the wrinkles. This is how we can help the patient after a treatment of teeth. And you do a smile treatment, but you can improve also around the smile. Using IPRF is also a good protocol to improve the bone graft, because when we inject the IPRF into the bone graft starts to be solid. And then we can cover with IPRF membranes. This is a case we made for a full mandible resorption. We used a titanium mesh and we wanted to make a GBR. But the IPRF will help us to shape the graft. And this is how today we can fix all the biomaterials with the IPRF, and we know that the mobility is slowing the angiogenesis. This is how we can treat today the bone graft. But there is now a new protocol, the IPRF liquid. When we inject the IPRF liquid, it clots immediately, and then we can make a very nice piece. We can say it's an omelette, it's a pizza, but the interest is that we have a solid graft in one shot. And then we can cut it, we can design exactly what we want to do. This is another case, you see, we just injected the IPRF liquid and then we have a full piece. And this piece we can go to fold it to design exactly what we want to do and to design the shape of the bone graft. This is an example. We make a full piece of bone graft and we go to apply it buccally when we do, for example, when we want to do a bone apposition in full arch immediate loading. And you see how now it's simple to manage the bone graft without any granule mobility. We can also use this piece of bone for nasal elevation. This is from my friend Patrick Palacci in Marseille. We go to the sinus now. We use piece of bone. And after we can place the implants. And look at the bone graft in the nasal place. Angiogenesis depends also on the biology. Usually when we want to make implants or bone graft, we ask the patient, are you a smoker? Have you diabetes? But this is not the right question. The first question that we have to ask is, first of all, can you build bone tissue? And the second question is, can you maintain this bone tissue? And we can ask this patient, because if he say, I can't, we will do nothing. It's better to do nothing than to go to a failure. We published this paper with my friends Fouad Kourib, Tiziano Testori, Komiyama from Japan, to inform the dentists that they do neglect too much, too often, the cholesterol and the vitamin D before the surgery, because the cholesterol deteriorates the bone health. the cholesterol metabolism occurs mainly in osteoblasts. And when we have high LDL, it's the factor, because LDL cholesterol is an oxidant. Then the bone metabolism decreases and the fat increase into the bone. And the bone becomes yellow. I believe that you know this guy, Per Brånemark. In 1985, more than 30 years ago, he was saying, when I see a yellow bone, I cancel the graft. He didn't know why, but now, today, we can explain why, because the patient had high cholesterol. There is not enough attention to the serum vitamin D, because with low vitamin D, the bone metabolism is slowed. With low vitamin D, there is a deficient immunity. With low vitamin D, there is a high inflammatory level. And we know that this high inflammatory level with a lot of giant cells will induce osteoclastogenesis and bone resorption. The right level is over 30 nanogram. Below it's insufficiency or deficiency when it's below 10 nanogram. Who are the deficient in the population? First of all is the old population. Above 65, we consider in medicine that 100% of the people are deficient. Take care about the obesity, because the vitamin D is moving to the fat. Take care about the black skin, because the sun cannot penetrate the skin. Take care about the depressive patient. They are almost depressive. Why depressive? Because today in the literature there is a very huge evidence that the depressive patients are deficient in vitamin D. And this study made in the University at Buffalo, they said antidepressant linked to tooth implant failure, because this is a problem of vitamin D. I got this email from a friend, implantologist, and he said, I placed a lot of implant and then she's spitting them one by one. And if you read the mail, she is also on antidepressive treatment. But if we check the blood test, we see that the LDL is high and the vitamin D is very low. Almost 100% of the depressive patients are deficient in vitamin D. Smoking is also very often associated with low vitamin D and high cholesterol. Today, from the medical point of view, the main problem of the smokers are not the smoking. The main problem is their vitamin D level and cholesterol level. And when you meet a resorption, it's not a surprise to see that the vitamin D is very low. When you meet a lot of resorption, look at the biology. It's not a surprise, because the patient cannot maintain the blood supply. This recent paper showed that when the vitamin D decrease, the early failure rate increase. The last sentence is when you meet, because I advise you to check the vitamin D, but when you meet a patient who is deficient, you have to organize the supplementation for the whole life, because if they are deficient today, they will be deficient tomorrow, the next year, and the next 10 years. Let's go to talk about angiogenesis again. This is the main topic. Don't reduce the blood supply coming from the person. When we do bone augmentation and we want to close the flap, we cut the period. Is it good to cut? No, we have to cut. But we know that this incision will reduce the blood supply. This incision is not a good protocol. And this is why I started to work on the concept to try to avoid the incision and to try to get the stem cells, because I want to work only on stem cells today. And this is how we can see the periosteum. Periosteum is a double layer membrane. One is external fibrous with collagen and fibroblast, and internal is with stem cells, osteoblasts and vessels. And this is how we designed with my friends Alain Simon-Piry and Jérôme Surménin the new technique for soft tissue elevation, the soft brushing technique. With this kit, we can elevate the periosteum without incision, without any bleeding. This is how we brush the flap when we elevate the flap. We are in the lingual flap, we do exactly the same. And you will see how now it's so easy to make an elevation of the lingual flap when you want to make a graft into the posterior mandible. After the brushing, after the soft brushing, you can get a lot of tissue without any incision. This is an example of what we do today. We have the tissue at the beginning and we brush it. Then we can see that we have 2 centimeters more elongation. This is the brushing of the lingual flap. How much tissue we can gain? We can gain 2 centimeters. It's amazing. But the same case in the buccal flap, when we brush the flap, even if we are close to the nerve, because we are just over the nerve. And you know that usually we have to go to the section of the nerve. It's not easy, it's difficult. Then we need just to brush. And when you brush, you can get 2 centimeters of the flap. This is how you can extend the flap without any periosteal incision. This case is interesting because it's already a failure of bone graft, and we wanted to make a vertical augmentation of 1 centimeter. We do the flap, we prepare the bone, and then we can go to brush. We use in this case the medium-sized brush. In the same time, we can remove the granules from the xenograft who was used at the beginning. Vertical augmentation, and look how the tissue is now going over the tooth. We use only screws because it's a good indication for this case to maintain the space without pressure. We use the APRF liquid to make a sticky bone. And then we can go to brush again because we want to extend more and more the tissue. And when we start to brush again, we can see that the tissue is more flexible. You see? Let's go with the XL brush instrument. And look how the soft tissue is so flexible now. And if we want to test, can we close the flap? Yes, of course, without any problem, without any tension. And we go to apply the suture, the apical mattress suture. I will tell about later. And you see, when we finish only the first suture, you see that the margins are in contact. This is the healing after 12 days, and this is the aspect of the bone after 12 days. The healing is absolutely amazing because if we don't cut the blood supply, obviously we will have a better healing. And this is a healing just only after 1 week. It appears in our experience, like after 3 weeks, when we come back after 1 week, we are really surprised to see how the healing is going so fast. Don't lose the blood supply by pressure and tension. This is a concept of Mrs. Mamoto from Boston University. She published this amazing paper in Nature in 2009, and I met her immediately after because I wanted to know more about the condition of the stability and the maintenance of the blood supply. If you don't press a tissue, you can get a full blood supply. But if you press it, you will lose it. This is a problem. If we apply a pressure, we will lose after a while the blood supply. And if we want to understand the Mamoto's rule, pressure is when we push, tension is when we pull, but it's the same amount of pressure. But who press the ball? The gum. Yes, the gum, because when we elevate the flap and we do augmentation, we create a pressure from the flap. But we have also the implant, which can be our enemy if we put it with too much pressure. After bone augmentation, we can see how the flap is pressing the bone and resorbing the bone. We put 2 mesh, and between the 2 mesh there is no protection from the pressure. And what happens? The resorption is only at the place where the bone graft is in contact with the flap. We have to remove the pressure, and this is why the Curry's technique is so popular, because the concept of Curry is to place 2 bone plates to remove and to block the pressure from the flap. When you use a titanium mesh, it's the same. The flap is not in contact with the bone graft inside the mesh. And when we use screws, it's the same. The screws, they block the pressure from the flap. We can talk also about tension. Tension, we forget that when we finish the surgery, we have to check, even if you do a tension-free flap closure, because you don't see too much the tension as you use anesthetics. And what is the function of the anesthetics is to paralyze the muscles. And if you want to see how the tension will occur when the patient is coming back home, you have to pull the lips or the cheeks. And then you see the biologic disaster if you pull the lips. Usually the patient, they talk, they smile, they eat, they cough. Means what they are doing, they are putting a lot of tension by the muscles. And this is why we have to check. I advise you to check all the time when you finish a surgery to see if there is any tension which will occur after the coming back home. Sorry. Periimplantitis, they say that it's an infectious disease. From the biological point of view, it's not the main problem. The main problem when you meet a periimplantitis is that maybe there is a high tension which induces the bone resorption. When you meet a periimplantitis, first of all, open the mouth and pull the lips, and you will see the tension. And you will understand why you are getting resorption. When you have a periimplantitis, open the mouth and pull the lips, and you will see the origin of the periimplantitis. And this is why, after my meeting with Mamoto, I proposed a new concept of suture to immobilize the flap, to reduce totally the tension and the mobility. It's the apical mattress suture technique. The apical mattress is simple. We go very deep into the vestibule, putting the needle into the full flap, and It's an horizontal mattress, but which is more apical. And when you tight the suture, you fix definitely the buccal flap, and you increase the thickness of the soft tissue without any connective tissue graft. When you do apical mattress, you remove the tension above the suture. And when you do the apical mattress, you change substantially the behavior, and look how the same patient is going now back home without any tension or mobility. The same patient again. On the left, we did classic suture. On the right, apical mattress. It means that we fix the buccal flap. This is what we want. When we finish the surgery, when we pull the lips, we see that the tension is above the sutures. And look at this case. The flaps are not closed. And you see that even if you pull the lips, the flap is not mobile. This is a proof that you can improve dramatically the blood supply if you fix the flap with your suture. Another lesson is about the suture. Again, we have to take care about the suture. Usually the dentists, when they tie the suture, they tie it a lot because they believe that they fix the flap. No. You create an ischemia of the tissue, and then you can see how you can kill the papilla just by a pressure on the papilla. If we talk on suture, we have to talk about the suture and the kind of suture. First of all, when we do a flap, we know that we need some days or some weeks to reattach, to see the reattachment of the periosteum. Usually when we do a flap, we need a certain force to remove it, but after 12 days, 1 month or 3 months, we see that the reattachment takes a long time, at least 1 month, at least 1 month. And then we have to stay with the suture for this time to be sure that the periosteum is fully attached to the bone again. And then, of course, we will forget the silk. We will forget the vicryl, because after 1 week we see the plaque. After 2 weeks, it's a disaster. The solution is only to use a monofilament. Nylon, if you want to get a cheap suture, use nylon. It doesn't matter. But we have another solution. Another good solution is to use an absorbable monofilament, which is the glycolon. The resorption of this suture is 3 to 4 weeks. It depends on the size. But you will not need to remove it, and you will stay the time needed to reattach, to get a good reattachment of the periosteum. And if you have a good reattachment, maybe you will get a good keratinization. But don't forget a very important protocol. When you use a monofil, any kind of monofil, please don't cut short. Because if you cut short, you will see the suture will become rigid, and then it hurts. The patient, they will get some scars or some pain. When you use a monofil, please cut long, 1 centimeter. Let's go to talk about the management of the flap after extraction. We know that after extraction, when we put implant, we lose the buccal bone. The literature says that it's because of extraction. We don't believe. Because when you put an implant and you try to close the gum, the flaps, you make a pressure on the crest. And then the pressure, according to the Mamoto's concept, the pressure will induce the bone resorption. When you put an implant and you see the resorption, maybe it's because your suture technique is not good. This kind of suture, you have to forget it definitely, because this is not a biological suture. If you want to make a right treatment, you can make extraction, you can put implant, maybe you can fill the gap with PRF, why not? Or with biomaterial, it doesn't matter. But please, the suture has to be biologic. Means the apical mattress is the only one way to do not resorb the crest. And you see with your eyes the result. You have a gum bead. What does it mean? It means that you have too much soft tissue. Means there is no pressure. And when you come back after 3 months, what do you see? You see a vertical bone augmentation of 3 millimeters without bone graft. And look, there is no resorption. You make bone and you don't resorb the crest because you did one special technique, the suture. I want to show you, you do extraction, you have a missed buccal bone. What is the main issue? Is to suture as well, and then you can rebuild the full crest without biomaterial, with nothing, only, of course, APRF. They say that after a flap, you meet bone resorption because of the flap. And this is why sometimes some people, they advise you to make a flapless technique. Don't worry about the flap. Don't worry, please. Because in this case, for example, the patient was treated in another office for extraction, and she came after 6 months to place implants. But the site was not very good for implant placement. We did a full flap, buccally and lingually. We filled the site with APRF, but the main issue is how do you manage the suture again? Because you are a surgeon and you have to understand that the main time of the surgery is the suture time. And if we manage with apical mattress and we see the gum bead, it's not a surprise after 4 months to see how the crest is totally stable, but it's growing. Yes, we have more bone than 4 months ago without any bone graft. Can we prevent the pressure from the flap? Why not? By screws. And if you put screws over the screws, above the screws, you will lose all the time because the flap again is coming to press. And this is an example. You want to make augmentation in the mandible, you make a lingual flap, you manage the soft tissue, and then the screws, they will guarantee you the volume. Look at this case. We wanted to compare bone blocks, bone plate, and screw. We did a full bone graft of the maxilla, and we covered with PRF without collagen membrane because APRF now is very powerful. And look, after 4 months, how is growing the bone around the screw. And if we compare the left and the right, we can see that the place of the GBR with the screw has more vasculature than the place with the bone blocks. When you place the implant, the bone loss starts with the preparation because we use a drill, and this drill is cutting some vessels. And of course we create an ischemia. We cut the vessels, and these vessels, they don't heal. We know that there is a narrow zone of dead and dying osteocyte in peri-implant bone. But if we put a high torque, maybe we will create a high ischemia, again, according to the Mamoto concept. When you place an implant, the major force is on the crest. But this bone is not a good bone. The cortical bone is not a bone with high blood supply. And then if you press it, you will lose it. This is why we meet the marginal bone loss it's only because we press the bone. But can we place an implant which is not compressive? Yes, we can first understand that when we put high torque, we will have an ischemia around the implant of the bone. And if we do not apply the torque, we will have a good bone stability. But we know since 14 years from Berglund that in the place where we placed an implant with high torque, the bone is healing as a remodeled bone, means it's healing as an ischemic bone. And this bone has a lot of chance to resorb. In the place where there is no pressure, the bone is a de novo bone, fully vascularized. This bone will never disappear. And this is why my advice is when we place implant, we have to over-prepare the cortical bone to remove all the pressure from the bone, from the implant to the bone. We have to over-prepare the cortical bone, and then there is a mini gap around the implant. But into the medullary bone, we can increase the torque. And you see that there is a new protocol to place an implant with two different torques. High in the base, zero at the crest. And this is the concept that I like. When you place an implant, you see a gap around the implant. Means it's only in the cortical, means there is no pressure. And we are sure that this bone will be a de novo bone which will never disappear. We can also place the implant in subcrestal position. And then in the cortical zone, without pressure, we can see that the bone is growing because there is no pressure. And this is why when we place an implant subcrestally and we use a switch platform, we see the bone growing above the implant because it's the best biologic condition for the blood supply. Increasing the stability results in an increase of the stress. And when you increase the stress, even if you use the best surface of titanium, you will lose the implants. This is not an infection. This is just a failure of the blood supply. Even if the titanium surface is one of the best, the pressure will create a bone resorption. We meet bone graft resorption after implant placement. We did a very nice graft, but after a while we lose the bone. We do bone graft, and after a while we lose the bone. Can we explain biologically this concept? But for sure, it's the implant placement who is the main issue. Hooke was living 3 centuries ago, but he left a testament for dentists and for implantologists. And to understand the Hooke's law, we have to understand that we have 3 kinds of tissue: the medullary bone, the cortical bone, and the grafted bone when we do re-entry. To understand the Hooke law, I take a picture of 3 strings. And the first one is very flexible, you see? The second is less flexible. And the third is not flexible. The first one is the medullary bone. It's extensible. The second one is the cortical bone, low flexibility. The third one is the grafted bone. When you put an implant in the medullary bone, you can put a high torque. The stress is not too much because the bone is flexible. When you put an implant on the cortical bone, immediately you have a high stress when you try to put a high torque. The grafted bone has a specificity. This is a very young tissue, 4, 5, 6 months, not too much. Means this bone has no elasticity. And when you put an implant, even if you use a low torque, you create a very high stress. This is the explanation why when you put an implant into a bone graft, you can lose the bone. It's not a problem, an histologic problem. It's not a problem of quality of bone. It is the problem that your hand is killing the bone. And this is why my advice is, please, when you place an implant into a grafted bone, please put it with a very low torque. And forget, definitely, to put this implant in immediate loading. This is why when we put an implant with high torque in a bone graft, we lose the graft. We can talk again about angiogenesis and the implant placement. Usually, we know that when the axis is not right, we start to lose bone. Why? Again, Mahamoto concept. The implant is not in the right axis and then it's pressing the bone and the bone resorbs. Can we place an implant with a perfect axis? Again, let's go to the anatomy. How can we help the implant placement with the anatomy? We have in the maxilla, for example, the nasopalatal canal. If you put a pin into this canal, you have the perfect axis of the implants. And you know that even if you change the bite, the canal is following the position of the maxilla. When you place a pin into the canal, you can place an implant in a perfect axis. Do we have to worry about the introduction of a pin in the canal? No, there is nothing into the canal. There is no risk to put a pin into the canal. And this is how we designed it with my friend Alain Simon-Pierry. He will be next August in New York in the Dental XP meeting. We designed the fast guide because we use the nasopalatal canal to place the implants in the right axis and totally parallel. This is how we can see the action of the fast guide. And again, can we maintain? Do we have a good maintenance of the bone around the implant when we use this kind of protocol? Yes. We waited 10 years to show you that. This is a case made in 2008, and 9 years after. What can we say? The soft tissue is not stable. The soft tissue is improving. Means the implants are working in the right axis. 2009, 7 years after, what do we see? Soft tissue improvement. Means all the situation, all the biologic situation is perfect. Vitamin D, cholesterol, tension, pressure, etc. When we place the implant and after 6 months we put the final prosthesis, 7 years after, what do we see? We see an improvement of the soft tissue. Means if all is working well, the tissue are growing. This is our lesson. After 7 years, we can see the stability of the buccal bone in the mandible and in the maxilla. My friends, it's time to conclude. It's not difficult to see the bone survival. It's not difficult. We just need to follow the biology all the time. It's not from a material, it's not from a surface, it's from you. Because if you do the right surgery, if you understand what you have to do, it's very easy to succeed. And then if you have all the biology in your hand, the use of growth factors should be a very good help. The growth factors then they work very nicely. The objective is because we are treating humans, don't forget, the objective is to maintain the tissues alive for the whole life. My friends, it's time to say goodbye. I hope I will see you in New York in August for the Dental XP meeting again. It will be my pleasure to present you all my new stuff, all my improvement in the PRF, in the soft tissue, in the soft brushing. We will present a lot of cases and a lot of conclusion. And it's also the opportunity to invite you to join us after New York in Nice, France, where I organize my world meeting on growth factors. The SciFac is my own meeting. We will have the specialists in the science, Mamoto, Ganati, Miron, specialists in bone graft, the divas, and the specialists in soft tissue. And I will be very happy to host you at this time. Thank you, my friends, and see you soon.